Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a virtual clinical pharmacy institute for capacity building for healthcare workers, the virtual clinical pharmacy institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very, very handy in your line of duty. So I welcome you all to part 120 of our pharmacotherapy MCQ series, Measuring in Infectious Diseases. Welcome. And the first question reads, Mr. P.K.O., a 48-year-old male patient, is rushed to your accident and emergency department by an ambulance while unconscious and in respiratory distress. The emergency medicine consultant administers naloxone to him and he regains consciousness. The chief complaints include chest pain, fevers, chills, and dyspnea, which have lasted 7 days. He is well known to the accident and emergency team. He uses cocaine and injects heroin when he can procure them. He injected heroin a short while before he was rushed to hospital. He has a past medical history of right upper extremity cellulitis and hypertension. On physical examination, it is established that he has a grade 3/6 systolic murmur. He has a painful erythematous nodules on the finger pads. A chest X-ray is done and there are no opacities and there are no consolidations noted either. A TTE is done and it returns negative. Then a transesophageal echocardiogram is done, the TEE, and a 7 mm vegetation is observed on the tricuspid valve, the TV. Some of his pertinent vital signs include a blood pressure of 163 systolic, 90 diastolic, a heart rate of 99 beats per minute, a respiratory rate of 24 breaths per minute, and he has a slight fever, body temperature of 39 degrees centigrade, and 3 sets of blood cultures, all grow Staphylococcus aureus. And that table shows his lab report with regard to susceptibilities of the Staph aureus to several antibiotics. It is resistant to ampicillin, it is sensitive or susceptible to clindamycin with an MIC of 1, it is resistant to erythromycin, susceptible to gentamicin, though the MIC is not established. It is susceptible to levofloxacin and the MIC is equal to or less than 1. It is susceptible to oxacillin, rifampicin, and even vancomycin. PKO is admitted to the general medical ward and empirically initiated on Piperacillin, tazobactam, and Vancomycin. He is stabilized. His repeat blood cultures show no growth at 24 hours from the time therapy was initiated. So my question to you is, which of the recommendations listed below would be the most appropriate for PKO's case now? Would it be advisable to stop piperacillin, tazobactam, and vancomycin and start nafcillin plus gentamicin for a 2-week course? Or would it be advisable to stop piperacillin, tazobactam and continue vancomycin but add gentamicin for 4 weeks? Or would you stop piperacillin, tazobactam and vancomycin and start nafcillin to complete a 2-week course? Or would you stop piperacillin, tazobactam and continue vancomycin to complete a 4-week course? I'll give you 10 seconds to choose the correct answer. In my opinion, it would be advisable to stop piperacillin, tazobactam and vancomycin and start nafcillin to complete a 2-week course of therapy. Remember, this patient has methicillin susceptible Staphylococcus aureus, the MSSA. His endocarditis, I'll repeat, is caused by MSSA. Thus, targeted therapy with an anti-staphylococcal beta-lactam should be given, and that makes answers D and B incorrect. Now, gentamicin is not needed in the case of native valve MSSA endocarditis, and that makes answers A and B incorrect. And I would like to add that because he has an uncomplicated infection, a 2-week course of adequate antimicrobial therapy would be indicated. That makes answer C correct in my opinion. Let's move to the next question, please. And it reads, Mr. P.Z.O, a 69-year-old male patient with a height of 67 inches and a weight of 72 kilos, was admitted to a general medical ward for the treatment of infective endocarditis caused by Enterococcus faecalis. He is on day 6 of 42 of treatment. Initial presentation was a 2+ pitting edema in his lower extremities, fatigue. He complained of decreased appetite, shortness of breath, and he has also shown marked improvement according to the team managing him. Some of the new findings include decreased urinary output over the past 48 hours. And some of his pertinent labs from yesterday's samples include a WBC of 7.6 times 10⁻³ cells per mm³. His serum creatinine is pretty high, 2.4 milligrams per deciliter. Remember, it was 0.8 milligrams per deciliter 4 days ago. And his gentamicin trough levels are 2.6 milligrams per deciliter. He is currently receiving 60 milligrams of gentamicin infused thrice daily and 2 grams of ampicillin infused every 4 hours. Some of his pertinent vital signs include a blood pressure of 135 systolic, 80 diastolic, a heart rate of 68 beats per minute, a respiratory rate of 16 breaths per minute. His body temperature is 37.2 degrees centigrade, and his oxygen sats are 97% on room air. He has a past medical history of systolic congestive heart failure, and he had infective endocarditis 2 years ago before this current admission. So my question to you is, which of the therapeutic plans listed below would be the most appropriate for Mr. P.Z.O now? Would you advise the team to discontinue current antibiotics and start daptomycin 500 milligrams IV daily, or would you discontinue gentamicin and start ceftriaxone 2 grams IV twice daily, infused over 30 minutes, or would you choose to hold gentamicin until the trough level falls below the 0.5 milligrams per deciliter, then change to gentamicin at a dose of 3 milligrams per kilo, that is 200 milligrams in a day, or would you choose to discontinue gentamicin? I'll give you 10 seconds to choose the correct answer. I would recommend we discontinue gentamicin and initiate ceftriaxone at a dose of 2 grams infused over 30 minutes twice daily. Now, this patient is experiencing acute kidney injury which is associated with gentamicin therapy, and I would like to add that synergistic therapy is needed for the treatment of E. faecalis infective endocarditis. Thus, discontinuation of gentamicin and continuing on ampicillin monotherapy is not appropriate. That makes answer D incorrect. I would like to add that while it is appropriate to hold gentamicin until the trough drops, in my opinion, the recommended dose of gentamicin for E. faecalis infective endocarditis is 3 milligrams per kilo per day in 2 to 3 divided doses, and not 3 milligrams per kilo per day. And that makes answer C wrong. That would be an underdose. And I would like to add that while daptomycin may be appropriate to treat this gentleman's infection, the first-line alternative treatment regimen for E. faecalis infective endocarditis is ampicillin plus ceftriaxone. That makes answer A correct. And by extension, it makes answer B the correct answer. Let's move to the next question, please. And the question reads, Mrs. G.P.M., a 45-year-old female patient, presents to your hospital for a routine checkup. She has a past medical history of mitral valve replacement, which was done 36 months ago. She also has a history of type 2 diabetes mellitus. Currently, she takes warfarin and metformin. On examination, they establish poor dentition, and large visible dental caries are seen on 2 of her molars on the right side of the jaw. She may need extraction of both teeth and placement of dental implants. And she seeks your opinion regarding antibiotic prophylaxis for the prevention of infective endocarditis. So my question to you is, which of the following responses would be the most appropriate in this clinical scenario? Would you recommend the use of a single tablet of 250 milligrams of ciprofloxacin 1 hour before the procedure? Or would you recommend the administration of 4 capsules of 500 milligrams amoxicillin orally once as a single dose an hour before the procedure? Or would you consider the administration of 2 grams of ampicillin IM 1 hour before the procedure? Or, in your opinion, is it true that no prophylaxis is indicated or necessary in this scenario? I'll give you 10 seconds to choose the correct answer. I would recommend the use of 4 capsules of amoxicillin 500 milligrams, which comes to 2 grams orally as a start dose 1 hour before the procedure. Remember, dental prophylaxis for infective endocarditis should be reserved for the highest risk groups, which include those with prosthetic cardiac valves, and that makes answer D incorrect. I'd like to add that antibiotic therapy should be targeted against streptococci in the oral cavity, and that makes A incorrect. Then I would like to add that the oral route is also preferred because of the potential adverse effects of intravenous administration, making answer C incorrect, and that leaves us with B as the correct answer. Let's move to the next question, please. And the next question reads, Mr. ILK, a 25-year-old male IV drug user who happens to administer methamphetamine and heroin, presents to your hospital. He has a past medical history of an infection caused by Streptococcus aeruginosus, complicated by an aortic root abscess. He presents with a chief complaint of low-grade fever, lethargy, which has lasted several days, and a new onset lower back pain. The blood cultures are obtained, and he is discharged home on naproxen to relieve his pain. 24 hours later, his blood cultures turn 2 of 2 positive for Staphylococcus aureus, which happens to be make A negative. He is summoned back to hospital and initiated on Nafcillin, administered at a dose of 2 grams IV every 4 hours. A TEE is performed, which demonstrates a recurrence of an aortic root abscess. An MRI spine is also done, which reveals a spinal epidural abscess. After 5 days of Nafcillin therapy, his serum creatinine increases from a baseline of 0.64 milligrams per deciliter to 1.1 milligrams per deciliter. So his creatinine clearance is around 80 ml per minute, and the potassium levels are 2.9 milliequivalents per liter despite aggressive supplementation. He reports a new onset fatigue and muscle weakness. So my question to you is, what would be the next best course of action in this clinical scenario? So would you switch from Nafcillin to cefazolin 2 grams IV thrice daily, or would you switch from Nafcillin to ceftriaxone 2 grams infused over 30 minutes once a day, or would you decrease the Nafcillin dose from 2 grams IV every 4 hours to 1 gram IV every 6 hours, or would you continue Nafcillin at the current dose and continue with aggressive potassium supplementation? I'll give you 10 seconds to choose the correct answer. I would switch from Nafcillin to cefazolin, dosed at 2 grams IV thrice daily. I would like to recommend that this patient is experiencing significant adverse events related to Nafcillin therapy. Now, while aggressive potassium supplementation may help with his hypokalemia, he is only likely experiencing an acute interstitial nephritis. So that makes answer D incorrect. There would be no need to supplement. We have to deal with the real issues here. Now, decreasing the Nafcillin dose based on adverse events is not appropriate in my opinion, and it puts the patient at a risk of development of resistance. It would be very risky to underdose, and that makes answer C incorrect in my opinion. Then I would like to emphasize that this gentleman should be switched to an alternative anti-staphylococcal beta-lactam such as cefazolin. That makes answer A the correct one from that list in my opinion, and that makes answer B incorrect. Let's move to the next question, please. And it reads, Mr. ILK lacks a comprehensive cover which could pay for home health care. He can't afford admission to a rehabilitation center either. He can only receive infusions, which requires a maximum of once daily antibiotic therapy at your adult accident and emergency department. Alternatively, your team will treat him with oral antibiotics. The pathogen, which is Staph aureus in this particular case, is pan-susceptible, susceptible to oxacillin, Vancomycin, Ciprofloxacin, rifampicin, and even doxycycline. And his serum creatinine has stabilized and is back to the baseline value, and his hypokalemia has also resolved. So my question to you is, basing on that information, which of the therapeutic options listed below would you propose for Mr. ILK's treatment now with the challenges he is facing? Would you settle for dalbavancin 1,500 milligrams IV as a single dose on day 1 and on day 8, or would you settle for deptomycin dosed at 8 milligrams per kilo IV on a daily basis, or would you settle for ciprofloxacin 750 milligrams taken orally twice daily alongside 300 milligrams of rifampicin taken orally thrice daily, or would you settle for 600 milligrams of linezolid taken orally twice daily? I'll give you 10 seconds to choose the correct answer. I would opt for deptomycin dosed at 8 milligrams per kilo IV on a daily basis. Remember, treatment of staphylococcal infective endocarditis with linezolid has been associated with poor outcomes. That makes answer D incorrect. In fact, by day 16 of therapy, thrombocytopenia ensues, which could complicate issues when you choose to use linezolid. So I would not use D. And ciprofloxacin and rifampicin is not an option for patients with complications such as an epidural abscess. That makes answer C incorrect. Then dalbavancin may be effective for treatment of complicated Staphylococcus aureus infections. However, data are lacking and it should not be considered a first-line alternative, and therefore that makes answer A incorrect as well. Now, just like to emphasize that daptomycin is FDA approved for the treatment of Staphylococcus aureus endocarditis, and it is an appropriate alternative treatment option in this particular case. So that makes answer B the correct choice in this particular scenario. So, ladies and gentlemen, my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to remember to give it a thumbs up, to like it, to share it widely with your peers, and to leave your comments at the bottom of the video. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come, and I thank you all very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you in subsequent videos. Thank you very much.